My name is Chris Marchand, director here at Echo Nevada. Thank you for joining us today on such short notice. It's pretty fantastic to see this kind of turnout. So our presenter today is going to be Kamisha Kazi from the Department of Public and Behavioral Health. I'm sure all of you have kind of heard about this multi-drug resistant, I guess, bacteria or infection, whatever, superbug going on. So Kamisha's going to give us the lowdown on the situation and also some of the prevention tips and information that she has. So I'm going to turn it over to Kamisha. Thank you for
my presentation
doing this
today.
Can you guys hear me okay?
Yep.
Alrighty. Good morning or good afternoon. My name is Kamisha Kazi. I'm the HI coordinator for the state of Nevada. And I'm just here to talk about the status of CRE in Nevada, give some CDC guidance on prevention tips, the cases that we've had thus far in Southern Nevada and Northern Nevada, and then reporting that we have going on right now and that's coming in the future. Okay, so our objectives for today are, like I said, define CRE, review current cases in Nevada, discuss CDC, CRE prevention, education, and isolation recommendations, explain the upcoming state reporting requirements and current voluntary reporting. Okay. Discuss the Nevada State Public Health Lab mechanism testing, and then the assistance that we can provide here for you at the Division of Public and Behavioral Health using the iCard tool, our TAP assessment tool, and then also the antimicrobial resistant regional laboratory Sentinel Lab program. So just a general definition of CRE, and this is based off of the information in the CRE toolkit, the 2015 update. CRE is considered the Enterobacteriaceae that are non-susceptible to carbapenems. The 2015 update, they updated the 2012 definition to include that it's resistant to any carbapenem antimicrobial or those that are documented to produce carbapenemase. Resistant, of course, as you know, is becoming increasingly common. The most spread, according to CDC, since 2000 has been due to CRE that produce Klebsiella pneumoniae carbapenemase. CPCRE was first identified in the US in 1996, and at the time of the 2015 update toolkit, Idaho and Maine were the only two states in the US that had not reported a CPCRE case. And I'm sure with the growth of this infection, that's probably changed now being 3 years since that update. So of particular concern are those that produce carbapenemase, which is an enzyme that neutralizes carbapenem antibiotics, which are the antibiotics of last resort. And some of those include KPC, NDM, OXA48, VIM, IMP, and so CDC and the ARLN network, which I'll speak about later, of course, are recommending that we take public health action. So in January of this year, CDC made reporting of CRE nationally notifiable. And as a result of that, in March of this year, we received our report of 2 cases from a local acute care facility here in Las Vegas. From then till yesterday, when I did the count, we've received 18 CRE cases thus far. 10 of them were Klebsiella pneumoniae. 1 was Pseudomonas aeruginosa. 4 CRO Enterobacter cloacae. 1 is Klebsiella and Enterobacter cloacae, 1 Klebsiella and Pseudomonas, and 1 Klebsiella enterococcus and VRE. From these cases, 7 of the specimens came from sputum, 6 from urine, 2 from blood, 1 from sputum and blood, 1 from a wound drainage, and 1 from sputum and urine. So we've worked with 5 acute care facilities, 5 long-term acute care facilities, 4 skilled nursing facilities, and 1 assisted living facility dealing with these cases. A lot of times when they get transferred from long-term acute care to acute care, that's when we receive the notification, or sometimes they're being transferred from skilled nursing to acute care. And what we do once we receive the cases, we do a trace back to see if we can identify where the infection occurred. Have they been, has it been a chronic illness for the patient, or did infection occur within one of the facilities? A lot of times these patients are very sick and they just kind of travel around the valley from facility to facility, depending on the type of care that's needed. So Washoe County has been collecting data on reporting data for CRE for, I believe, maybe about 2 years. And this is the information from their 2018 quarter 1 report. In January, they received 3 CRE reports and 5 CRPA reports. In February, there were 4 CRE and 2 CRPA reports. And in March, there were 2 CRE and 9 CRPA reports. From these patients, 14 were inpatient, 8 were outpatient, 2 were in ICU, and 1 was in the skilled nursing facility. So recommendations for control of CRE are the same recommendations for a lot of the infections that you guys see within your facility. Of course, first being hand hygiene. Some of you guys in the iCard, I'm getting some feedback. A lot of you participated in the iCard activity, and hand hygiene was one of the gaps identified statewide. We have a hand hygiene training on our website.
Kamisha, can I interrupt real quick? Sorry to interrupt. For those of you that are on with us, can you please make sure that your computer is muted, your microphone is muted? It's in the lower left-hand corner. We are getting some feedback, and because this is being recorded to be available at a later date, we want to make sure that the audio is as clean as possible. So if you could just take a quick second, make sure you're on mute. That would be greatly appreciated. Thank you. Go ahead, Kamisha.
Okay. So as I was speaking about hand hygiene, your basic soap and water, alcohol-based hand rub needed before you're in contact with patient, after working with your patients. Anytime you're coming from the restroom, eating, the different guidelines that CDC provides of when hand hygiene is necessary. Also performing audits on your staff to make sure they're compliant with hand hygiene. Secret Shoppers is a good program that a lot of facilities use. Having someone from a different department just kind of, meander around, not very obvious of what they're doing. And then a lot of times when you have, what we were seeing was when a person from the specific unit was conducting surveillance on their coworkers within that unit, everybody was being marked as having 100% hand hygiene compliance. When they switched that process, those numbers changed. So having someone from a different unit was proving to be a good method to actually get valuable data on what hand hygiene is looking like within the medical facility. Also having a system in place to identify patients with a history of CRE upon admission. Screening of patients. A lot of these cases that we're receiving are being identified upon admission due to screening. We'll talk about the interfacility transfer form later, but we're finding that with working with the cases that we've had thus far, a lot of this information is not being distributed from the transferring facility to the receiving facility. So a lot of times they don't even know these patients have CRE or other MDROs until they do their own screening at admission, or until they start to exhibit symptoms, and then screening is done at that point. We do need to have the communication from facility to facility, and it kind of goes either way. A lot of times acute care is saying that skilled nursing and long-term acute care, it's not providing them the information, and the same with long-term acute care and skilled nursing. When these patients come from acute care, they're not receiving the information, or if they do receive it, it's just not consistent. So we do need to develop a consistent policy for facilities to transfer this information from when they're transferring the patient out of their facility into the skilled nursing acute care or long-term acute care, to make sure that they know prior to admission that these patients are positive for CRE, infection or colonization, and make sure they can put them on the proper contact precautions and have everything set up that's needed to properly take care of this patient and make sure these infections aren't spreading throughout our healthcare facilities in the state. Empiric contact precautions, making sure that the patients have the PPE available outside the room, proper signage for anybody coming into the room. A lot of times it's really good to have visitors, a note on there for visitors to go to the nurses station before going in, just to receive some education on the type of bacteria that their family member or loved one has. Why contact precautions are needed, that they don't want to take these infections home to their families, and just giving them the education needed before going in without donning the proper PPE. Education and training for all healthcare personnel on the proper use of contact precaution. While we conducted the iCard, a lot of times staff were not properly donning PPE. They weren't properly doffing PPE. We've observed individuals walking out of rooms that patients are on contact precaution and they still have their PPE on, or hand hygiene wasn't performed. So just making sure your staff is properly educated and training, and then like I said earlier, conducting audits and surveillance to make sure they're adhering to your facility's policies and procedures. The fifth item is minimizing device use. Discontinuing devices when possible also helps to cut down your device utilization, device-associated infections, and just eliminating a source of infection for these patients. As I mentioned earlier, interfacility communication and identification of CRE patients at admission. Patient and staff cohorting. When available, cohort your CRE colonized or infected patients and the staff that care for them, even if the patients are housed in single rooms. If the number of your single patient rooms are limited, reserve the rooms for patients with highest risk of transmission. And that's based upon CDC guidance. Screening, like we mentioned earlier, contacts of CRE patients. In the event that you have a patient, screening those on the same hall or any roommates that they may have had to make sure the infection hasn't spread it, and then active surveillance testing. Environmental cleaning is definitely important in this case and in preventing any healthcare associated infections. A lot of times environmental services aren't brought into the loop as a prevention, necessary for prevention. Sometimes we've seen where they've had contract companies, and they're not really sure what the contract company is doing, the type of chemicals they're using. Have they been trained? Are they receiving regular training at higher and at least annually? So you want to make sure your EVS services are in the loop, that they understand that their job is important in eliminating and decreasing the risk of transmission within the facility. Make sure they're performing daily cleaning and disinfection in patient, including areas in close proximity to the patient, the bed rails, patient trays, light switches, doorknobs, the toilet handle on the toilet, different things like that that are high touch surfaces. Terminally cleaning the rooms of CRE patients once discharged. Monitoring the cleaning process to ensure all surfaces are adequately cleaned and disinfected. They have different tools you can use, sprays where you can mark the rooms and then have your EVS staff go in, do their cleaning and disinfection, and then come back in with a UV light to see if any of the marks were made. And that's been a very great tool that we've been using with facilities that we've been going into to show them where high touch surfaces that are supposed to be properly cleaned and disinfected, especially upon a terminal clean, are either completely missed or kind of rubbed over. Our marks will be smeared but not completely removed. So proper training with your environmental services, their managers, and then making sure that they're being audited to look at their performance and make sure they are properly cleaning those rooms and disinfecting.
Hey, Kamisha, we do have one question that came over chat.
Okay.
The question is, do you have recommendations, or are there recommendations for disinfectants?
We always lead people towards the, it's evading me right now, but they have a list of the items, basically the disinfectants that are, oh, there we go, the EPA registered list. Thank you. They have a list of disinfectants that you can use within your hospital facility, because we did find where, especially during outbreaks, when we asked them, okay, what are you guys using to clean and disinfect? A lot of them, well, not a lot of, but we did find some that were using Clorox bleach wipes. And then when we asked, are they hospital grade, they were using like the kind you would use in your home. So making sure your staff are educated on hospital grade cleaners, disinfectants, the wipes, making sure they are effective against the organisms that you're seeing in your facility. Because if you're using, you know, a hospital grade disinfectant, but it's not effective towards, let's say, C. diff or something like that, then it's not going to be effective towards eliminating that organism from that room. Were there any other questions?
Just wanted to make somebody asked if the handouts will be available, and yes, they will.
Yeah, I'll send a link for that out in the chat right now.
Okay, and this is just visual for you on performing the proper use of contact precautions. Includes performing hand hygiene before donning your gowns, your glove, or mask, whatever PPE is needed for that particular patient. Donning your gown and gloves before entering the patient's room, and then removing your PPE and performing hand hygiene prior to exiting the patient's room. So for patients that need to be on contact precautions, you want to identify these patients prior to admission so that you know exactly what's needed. You can educate your staff on the patient that's coming in. Excuse me. Patients who are colonized or infected with CRE do need to be on contact precautions. Make sure proper signage is posted for your staff and visitors and others that will be coming into the rooms, liaisons. We've observed liaisons walking, you know, right into patient room, and the signage and PPE is right there, but that education is lacking. Excuse me. And they go right into these patient rooms. Ensuring, excuse me, proper PPE is, just a moment, please. I'm sorry, something's choking me. Ensuring proper PPE is available before entering the patient room and instructing visitors to visit the nursing station for education. So this was one big question we had about, I don't know what we have in this office. Sinuses, I apologize. So there is no firm recommendation from CDC on when to discontinue contact precautions for patients that are infected or colonized. They did state that CRE colonization can be prolonged for 6 months or more. So before you look at discontinuing contact precautions for a patient that's been colonized or infected with CRE, They do recommend that you take more than one culture to collect in order to improve your sensitivity. Excuse me, I apologize. So as I mentioned before, CDC added CPCRE to their National Notifiable Disease Surveillance System in January of 2018, and this includes CPCRE, Enterobacter species, E. coli, and Klebsiella species. At this time, the reporting that Nevada is doing is voluntary, but we are working on a state mandate for reporting that is in the process of being drafted and going through the necessary process. Once we get to a point of everything's been drafted, we will have town hall meetings, for lack of a better term, and then there'll also be questionnaires that go out for all of the healthcare facilities in the state, so that you can, state your thoughts and opinions on the drafted mandate before it goes through the approval process. So right now we're collecting cases on CRE. Your reports can be faxed us here in the Las Vegas office, and the number's there. And you can send us the patient name, first and last, the date of birth, and the positive labs, and then we'll contact you to gather the additional information that we need. Part of the reporting that will be implemented in the mandatory state reporting, will be on Acinetobacter, carbapenem-resistant Acinetobacter, CRE, and then carbapenem-resistant Pseudomonas. Another resource for you guys is the Nevada State Public Health Lab mechanism testing. They do provide shipping supplies for you to ship your specimens to them to test to see if the organism is carbapenemase producing or non-carbapenemase producing, which is very important. If you need to get in contact with the Nevada State Public Health Lab, you can contact my office, and my contact information is at the end of this presentation. And we can send you the shipping supplies and the forms. You can work with your lab. A lot of times they'll have the form that the State Public Health Lab uses. But if you need any of the supplies or information, you can just contact us, and we'll work with you to get that information, those specimens, up to the state lab for mechanism testing. Another resource is the Antibiotic Resistant Laboratory Network, or ARLN. And this lab is up in Washington State. They're our regional lab, and they are seeking laboratories in Nevada to serve as Sentinel sites. They do have a list of organisms that they would like for you to send, but you can select which organisms you want to track through your facility and send to their lab. Some of the benefits of being part of the Sentinel Lab program are you have access to advanced laboratory testing. There's free shipping. They provide all of the supplies and pay for the shipping for everything you send to them. You do get a certificate of participation for being part of the ARN Lab Network, and then you receive statewide MDRO reports. Those reports also come to me, so it definitely, being part of this program will help us understand our burden within the state prior to reporting becoming mandatory. They will work with you to develop the best strategy, so it's not an overburden on your lab or any of the staff. And some of the items they are collecting, specimens they're collecting are, let me find my list. Getting some feedback. Okay, they're collecting specimens on carbapenem-resistant E. coli, Klebsiella, Enterobacter, and Pseudomonas. And then they're also collecting data on all carbapenem-resistant all Candida auris, and then other specific Candida species. So if you want more information on becoming a Sentinel Lab, waiting for my slide to come up. There we go. You can contact Sophie Hun. She's with the Washington State Department of Health, and this is her email address, or you can contact ARLN directly or call them at the number listed here. So the transfer form is something that we've really been trying to get facilities to use for a couple of years now. And we're asking for this form to be used because, like I said earlier, a lot of the pertinent information on patients when they're getting transferred is not getting communicated to the receiving facility. A lot of times the facilities are saying it's already in the packet of information that they send over, but either I'm not sure if the information is being misplaced, if it's, you know, so much information that they don't have the time to go through everything. But this is a quick way to get everything that they'll need is in regards to antibiotic treatment, length of treatment, MDROs, that they have any devices that have been used or are being used on the patient without having to run their own lab testing and screening on the patients. So it puts everything in one place. This can be sent over to the infection preventionist or whoever you guys discuss is the person that you would like to send it to. So that they have this information and they can provide the proper treatment and precautions for patients before coming into the facility. Everything is ready for them and they can go right into the necessary precautions. This form is on our website as well. And we can send the link out through Project Echo to our training page. And it also has, like I said, the online trainings. There's videos on there that you guys can use for trainings. We have the transfer form. There's some other great information on our page. I think they just posted it through the chat. Next slide. So now I'll discuss some of the assistance we can provide with DPBH through our iCard assessment, and Chidima and Joku, who also works with our HAI team, will discuss the TAP assessment. So the iCard tool is a comprehensive tool that we use to assess overall infection control programs. We've used it thus far in 29 acute care facilities, 18 long-term care facilities, and 13 outpatient facilities. And for acute care, oh, you go back one slide. Thanks. For acute care, that includes short-term acute and long-term acute. The tool that we use works for both. They don't split those two facility types. So it is the same tool used for both of those. So some of the topics that are covered on the iCard tool, and this is for, there's various topics that are covered based on the facility type, but these are all of the topics that are covered between those tools. Infection prevention, education, and infrastructure, CAUTI, CLABSI, VAE, MDRO, injection safety, environmental services, device reprocessing, and antibiotic stewardship. So basically what we do with this tool is we come in and we look at all of your policies and procedures in these various areas, look at auditing, training for your staff, how often they're being trained. We look at proof of training in the staff records. Are you guys screening for a TB upon hire? Influenza vaccination, is it offered? What are your rates? Pneumococcal vaccination. We look at your injection safety programs. We do observations, point of care testing, EVS, when we observe them when they go into the room, and see where we can identify gaps within your facility and then help you close those gaps to provide a more proficient infection prevention program. Go to the next slide. So at this time, Chidima's going to talk about the TAP assessment. This is a new tool that we are in the process of sending out to facilities to use, but this is something that CDC has also provided for facilities, and she's going to discuss how we can use this tool with your facilities to also identify infection prevention gaps.
Hi, we're having just a little trouble hearing you, Chidima. Maybe get a little closer to your microphone.
Oh, okay. Can you hear me better?
It's still a little unclear.
1 second.
Okay.
All right, hi everyone. So following the iCard, as Kamisha mentioned, we did iCard um, assessments, and following the iCards, we sent out some TAP reports to facilities, and basically the TAP reports highlight any burdens in any units in the facility. So it highlights what units the facility is having a high burden of infection, and helps facilities know that this is where they can focus their infection prevention activities. So the TAP assessment is a framework that works off of the TAP report, and it's a framework for quality improvement for healthcare facilities, and you can use this to get a deeper dive where indicated for your various units. And this is an example of what the TAP assessment looks like. We do have these available to circulate by email, or we also recently acquired the SurveyMonkey, which will be sending out. The SurveyMonkey has the same questions, so that it gives the frontline staff the ability to answer these questions in their own time at their own pace. And we can go on to the next slide, please. Okay, so this is a brief example of what is covered in the TAP assessments. So it's meant to capture the frontline staff opinion on how the facility is doing. So you can answer the questions and provide a Dropbox if possible for your staff to submit these assessments either in paper copy or by email, or to fill out the SurveyMonkey. Okay, the next slide. And this is the example of, on our end, we'll put all the assessments together. So when all your staff have answered the questions, we can look at each unit and see how everyone answered. And it's a good way to see how, if there's any delineation of roles in the facility, if everyone thinks that, that there is training being provided for hand hygiene or anything that they need, and if there is staff that are leading these training for the various staff members. So the TAP assessment serves to capture the awareness and perceptions of policies and practices in various facilities, and to also look at the units that these assessments are being administered in. And we'll be more than happy to help work with facilities throughout the state.
Alrighty, so this is the contact information for everybody on the HAI team. Myself, Adrian, and Chidima are all in Southern Nevada. Jessica is in Northern Nevada. And any of us are more than happy to come out to your facilities to perform iCard to help with the TAP assessments. Just any assistance that you need infection prevention wise. We do trainings. We help perform. Jessica has done a lot of the environmental services audits with the tool where we place the markings, and to see how the environmental service team is efficiently cleaning and disinfecting the room, and then providing training. We hosted a training for 2 facilities up north for EVS. They got all their EVS managers and staff together, and we provided a training just to go over the importance of EVS and their role in infection prevention, and breaking that chain of infection within a healthcare facility. You know, they reported voluntarily, as I mentioned, and they've been a great help with, you know, doing research on the cases. If there's any issues we've run into, just being totally transparent with us, and then allowing us to help them close any gaps that have been identified. Thank you to Project ECHO for providing this avenue for providing the training today at such short notice. Health Insight and the assistance they provided with this, our Division of Public and Behavioral Health Administration, and our HAI program staff. Any questions?
Sorry, Commissioner, we just missed the first part of that. It seemed like you went back on mute.
Oh, I was just saying this was the references that we use for the training. Unfortunately, Washoe County doesn't have a link for their Q1 report, but they do have a lot of good information on CPO and CRO on their website. They have a little search bar, and if you put in CPO, it pulls up a lot of great reports for you guys to read through. Are there any questions?
Yeah, we'll open it up for questions. Feel free to send them in through the chat or take yourself off mute. If you're on Zoom, it's just the little microphone icon. It should be in the lower left corner of your screen. Or if you're joined on phone, it's *6. Commissioner, can you see the question?
Yeah, has this been called an outbreak at this point? Not for Southern Nevada. I did discuss that with our chief medical officer, and we don't have the data necessary to say that there's an outbreak. This definitely is of great concern. Receiving the reports from you guys will help us get a better picture of what we're seeing down here in the South. As I mentioned before, Washoe County has been collecting data for about 2 years, so they have a better picture of what's going on up there for the facilities that are located within Washoe County. We did identify an outbreak in one long-term care acute facility, long-term acute care facility, and worked with that facility, and we haven't seen any further transmission of infection there. You're welcome.
So I'm sending something out in the chat right now just about where everyone can get the slides. But you can also just contact us by email at projectecho@med.unr.edu to request the slides as well. And another question here, Kamisha, are there special culture swabs to use?
Not that I'm aware of. The state public health lab just provided me with test tubes and then actual containers to put the test tubes in to mail out. So I don't think there's any special cultural swabs. But I can definitely, ask them if there's, what the regulations or guidelines are on that, and get that information out to you guys.
And our email address is projectecho@med, that's med.unr.edu. And I just sent it out in the chat as well. Kamisha, what color tube top is that?
I believe it's a black one. Yeah, it's black. It's Rimmel Nutrient Auger. So that's what they sent to collect the specimens in, and then that just gets shipped to State Public Health Lab, and then they conduct the mechanism testing on that.
Okay. And how important is it to determine if CRE is carbapenemase producing?
That's very important to determine. That's one of the things CDC would like for us to look at, if it's a non-CP-CRE versus a CP-CRE, because if it is carbapenemase producing, then it has the ability to share that resistance with other bacteria that may be present in that patient, which limits or eliminates treatment for that patient. So that's very, and if we can, that's why we would like for the specimens to go to state lab, because they can help us make that determination. But if we don't have the specimens to send up, we're just treating every patient like they're CP-CRE if that status is unknown.
Any other questions? Please feel free to keep sending them in through the chat, or take yourself off mute. Again, that should be the icon in the lower left corner, or *6 if you're on phone.
Now's the time to get information from the source, so please don't be shy. There probably isn't any silly questions, so feel free to utilize this time.
Oh, you're welcome, Lisa. Oh, sure. Can you guys see the tube?
Mhm.
Anything on my end? But oh, there we go. So this is the tube that State Lab provided for us, and sorry, and this is the container used to mail the test tube in. So we have, I have some of these in my office. I can definitely request some more from State Lab. And then, like I mentioned, if you would like to be a Sentinel Lab, they provide you with all of these supplies, and the cost of shipping they cover as well.
And I'll just share your show your contact information again so everybody has it.
Okay.
Any other questions out there?
There we go.
So Kamisha, when a lab report from an outside lab like Quest shows CRE, how soon after do you want a second culture to be collected and sent to the state lab?
As soon as possible. That's a problem that we ran into when we have received reports. By the time we receive them, the specimens have been destroyed, and some of the procedures to collect the specimen are very invasive, and we don't want to put the patient through that. So as soon as possible that you can get a specimen to us for the state public health lab, the sooner the better.
All right, thanks for the question. Can the outside lab send the specimen to the state lab?
Yes.
Okay.
They just need to use the paperwork that State Lab requests, and I have that paperwork as well. It's just a form that they fill out. They may already have it. They just sent it to me just in case it's needed, but they can send it up to State Lab. They just need to put that they need to do CRE testing on it, and then the necessary contact information so they know where to send those results to.
Hey, Kamisha, is there is with all of this emerging, is there going to be any additional follow-up presentations or information that's going to be pushed out in relation to this that you want to give people a heads up on?
We do have a technical bulletin that'll be coming out that provides some of the same information, just in a shorter form. It's only a one-pager, but just a short background, the case of what we're seeing here in Nevada, and then recommendations. It has a link to the transfer form, my contact information, and then also you can contact your local health authority as well. So that is one source of information that's coming out, and working with our administration, I'm sure we'll have more education or information coming in the future, especially in regards to the mandated reporting. There'll be a lot of information coming out in regards to that.
Perfect. And just a little bit of house cleaning here. If any of you do need CME or CEUs for this presentation, feel free to fill out an evaluation on the Project Echo website and send those in. We will make sure that you get credit for this. And also, for those of you that didn't put your name in your logon screen, I'm not quite sure who you are, so it'd be great if you just email us, the email that we've sent out, projectecho@ med.unr.edu, and just let us know who you were. This is an incredible turnout, and we're really just thrilled at the support that we've seen for this on such short notice. So thank you all for taking the time to join us. And Kamisha, thank you for the presentation, being able to round up this information on short notice as well.
Definitely.
We also have the HAI task force meeting, and that's another forum for you guys to call in and have a say in what we're doing as a state as far as infection prevention activities, trainings, different things like that. So please bring your ideas to that meeting. Our meeting for May got canceled, but we will have our next meeting will be in July. If you're not on that contact email list, you can email me and I can add you.
Kamisha froze.
Proper antibiotic stewardship in our facilities, education, trainings as well. We have our statewide training that we hold annually. So if you would like to present or have a suggestion for topics, I'm sure CRE will be one of our topics this year. You can also send that information to me as well.
There was another question that came in. If and when there is a CRE positive test, should it be reported to the Southern Nevada Health District as well as to you?
If you report it to them, it gets to me either way. You can send it to me. We're actually have a call after this to talk with them on how we're going to work together. If you're in Washoe County, you can just continue to report to them, and then they send me a report. Since they already have their mandate going on up north, I don't want you guys to have to double report until we get the state mandate out. So right now for the voluntary state reporting, if you're in Washoe County, you can just continue to send your reports to them through the avenues that they provided for you guys. Any other questions?
Not that I'm seeing, no, but we do have a few more minutes, so send them in, please, if you have them.
All right, we'll call it a wrap. Thank you, everybody, for joining us. And please feel free to reach out if you need anything from any of the stakeholders that were involved.
Thank you, guys.